right, might as well kick things off. Hello and welcome to the healthcare panel of Techlandia Summit 21, Equity and Resiliency in Public Health, Lessons Learned from the Past Year. I'm Skip Newberry, President and CEO of the Technology Association of Oregon, and I'll be your facilitator of this session along with Riley O'Brien, Vice President, Events and Experiences, who'll be coordinating back-end support. You'll find me in chat most throughout the event, and we are excited to have you join us as our panelists share what they learned from their research and frontline experience during the past year. They'll be offering recommendations for improvements that can be made to our healthcare system to ensure outcomes that are more equitable and effective. And if this session's anything like the one we had this morning, people will be popping in throughout. So we'll make sure to get people up to speed via chat as they hop into the conversation. A couple of rules of engagement before we start. All participants have been muted. Please remain on mute unless the TAO staff member unmutes you and calls on you to talk. You may ask or respond to questions in the chat box publicly or privately by directing your message to me or special events. We'll monitor the chat box and respond throughout the discussion. Please put Q&A before your question if you want it to be held for the panel. And we'll ask you all to engage via the participant icon on your screen. We also ask that you please engage with us on social media during the session. We're excited to share what's happening throughout the Techlandia Summit and to get participant takeaways from our events. This session is also being recorded and will be found on TAO's YouTube within 24 hours of this event. We hope you'll join us for other sessions during Techlandia Summit, including tomorrow's sessions focused on climate and the environment at 9 a.m. and 11 a.m. respectively. A huge thank you to all of our investors in Techlandia Summit. We appreciate your support and are excited to explore topics related to agriculture, healthcare, climate and environment, and infrastructure throughout the week. And those supporters include Comcast Business, Fortinet, Grail, and SAP. Finally, it's my pleasure to introduce our moderator for this session, Senior Researcher at the Center for Black Innovation, Vanessa Vassall. Thank you.
Thank you so much, Skip, and good afternoon and good morning to everyone. I am looking forward to this panel as well. Once again, my name is Vanessa Vassall. I am the Senior Researcher at the Center for Black Innovation, and also I am the National Programs Director for Maternal Health and Environmental Justice for Black Millennials for Flint. So I'm very, very interested in what our fantastic panelists will be discussing today. So without further ado, I'll give a brief introduction of each panelist, and then I'll also allow them to share a little bit about themselves as they respond to our questions today. So first, we will have Terralyn Wiley, who is Senior Program Manager at Multnomah County. We also have Dr. Eric Fung, who is the Vice President of Clinical Development at Grail. And lastly, we have Rose Locklear, who is the Field Services Program Manager at the Oregon Office of Rural Health. So we'd like to thank you all for engaging today, and let's go ahead and get started. So first, it's often been said that COVID did not create any new trends in health, but rather it accelerated those that were already in motion. And one of those trends in particular was remote care or virtualized care. What are some examples of ways that healthcare organizations are using technology to reach their patients? So I guess we could start with our resident physician. Eric, let's start with you.
Thank you, Vanessa, and I'm really appreciative of the opportunity to participate in this panel. So yes, COVID was a huge natural experiment, really, in the way that we deliver healthcare. And we at Grail were actually in the middle of conducting a fairly substantial study in which we were looking at the implementation of multi-cancer early detection testing for the first time. And COVID hit us right in the middle of that. And so I can speak to two very specific examples of where COVID had an impact, and that impact, I think, will actually demonstrate how COVID is going to permanently change the landscape of some of these elements. So the first is, because this was a study, we were obviously enrolling participants. And the traditional model for enrolling participants, of course, is a potential participant comes into the clinic, is evaluated, and then a study coordinator will determine whether that person is eligible for a study. Of course, with a dramatic reduction of potential participants coming into the clinic, this model did not work. And so we had to rethink how we could enroll participants, how we could screen participants, and then how we could actually monitor that data. And so all of this meant that we had needed to translate to a much more remote approach. The other element that we observed in Pathfinder, which is our multi-cancer early detection study, was that obviously when individuals are being worked up for any type of potential cancer, the traditional model, again, was obviously come in for every single visit. And there was, of course, a transition to many more virtual visits. And I'm sure everyone on this panel has seen that. And I think virtual visits are here to stay. And so those are two very specific examples where I can say that some of these were conceptualized and were practiced, but not very frequently. And COVID accelerated both of those practices.
Thank you. And Teralyn or Rose, would you like to talk about how the county, as well as how in rural health, virtual care changed or accelerated during COVID?
Thanks, Vanessa. Yeah, I can chime in. I would say at Multnomah County this past year during the pandemic, they've made efforts to be more intentional in their patient care and their outreach and their responses to community members. And so, of course, the various approaches have utilized tech. One example I can think of in particular is our health department is using a phone app that not only helps them do their contact tracing, but also connects patients to wraparound services. So instead of just getting questions about what are your symptoms, how are you feeling, you also get questions about your overall wellness. So like, what do you need? And that comes with resources. So it's like, not only is a patient COVID positive, but if they need groceries, if they need funds to pay for any kind of bills that they may have had and maybe missed out on work and need assistance, the county also can step in and say, okay, well, we've got these resources. So not only can we help you manage your 2 weeks of time to go through the COVID situation, but you also get these resources to help you live as fully as you can for the next 2 weeks. And so that, I feel like that's a really great example of efforts to be more intentional. And yeah, there's just, and there's a lot of other health organizations that we've partnered with in our community that are doing that same thing.
Yeah, from the rural perspective, there has been a substantial amount of change and adoption for virtual care. I think a lot of this, well, obviously, we had massive relaxation when it came to rules and regulations at the state and the federal level. And so when we look at the demographic of rural communities, we certainly have a lot of 65 plus individuals residing in rural communities. So the Medicare relaxations were extremely important and really facilitated this massive adoption. But it wasn't just Medicare, right? It was this real cohesive relaxation across Medicaid, Medicare, and private that made as well as allowing for the safety net facilities, rural health clinics, and federally qualified health centers to operate as the distant site provider of care. So really the perfect storm, so to speak, to increase accessibility to virtual care and for rural providers to actually get reimbursed at a decent rate to provide that care. So prior to COVID, there was certainly virtual care existing in rural communities, critical access hospitals. A lot of specialty services were offered, but they were really operating as the originating site where the patient would present to and were able to connect with their specialty providers at larger tertiary care centers. Fast forward to public health emergency, and we're seeing the rural health clinics and federally qualified health centers really be able to offer primary care services, follow-up care, medication management, sort of those one and done easy visits that are able to be conducted over technology. So massive expansion of primary care services and also behavioral health, right? I think it's been a big silver lining of the pandemic. But we know out in rural communities, right? Like if we look at our office does a primary care and different care capacity ratios. And so we certainly have adequate primary care and mental health within our state, but it's often siloed in certain communities or areas. And so virtual care and behavioral and primary care has been able to expand out into our rural communities in a lot of really creative ways. So that's been a real positive and neat thing to see happen.
Thanks for that. And, you talked about specialty care, and I guess with that, I'd like to transition to another question about rolling out new care. When you're looking to roll out new healthcare solutions for practitioners, what should be considered when it comes to ensuring that the technology is indeed adopted?
Well, maybe I can get the ball rolling. So I think obviously before any technology is rolled out into the community, we need to make sure that it is a scientifically valid new offering. So the method by which we develop the novel technology, the novel test or novel therapeutic, whatever it is, needs to have been developed with extreme scientific rigor, needs to be vetted by KOLs and so forth. So, that's kind of table stakes, so to speak. Once we believe that the data are supportive of the clinical need and the clinical validity of that new technology, then it's really a matter of execution on several fronts. The first is awareness, right? We need that awareness by various stakeholders. Those stakeholders include physicians, both primary care and specialists, and other physicians who might be impacted by the presence of this new technology. The second is the right partnerships. Whether those partnerships are with healthcare systems, with academic medical centers, or other stakeholders who can actually drive the accessibility of that new technology. And then in today's, of course, healthcare landscape, we always have to think about coverage and access, and no technology is ultimately going to reach the people that it needs to reach until there is broad coverage and access, and that needs to be a part of the conversation from the very beginning. So I think that as we think about technology rollout, it starts with making sure that we believe in the technology, that's clinically useful, and that it's the right conversations with a broad set of stakeholders: physicians, patients, payers, and regulators.
Thanks for that. And Rose and Tara Lynn, especially the conversation about partners. Do you all have responses about adopting new technology as it rolls out?
Yeah, sure. I would say, especially when it comes to partners, I think bringing them to the table before we have the machine already created is a big step, or it's an important step in increasing outreach and access. We see them as the experts on working with our most vulnerable communities. From a system standpoint, communities don't always necessarily trust institutions. And so when it comes to partners, we bring them to the table as valuable and as really like the implementers. And so bringing them to the table at the very beginning, saying like, hey, this is the product, or this is the approach that we're thinking of using. How can we make this better or more accessible, or what input before we actually make this a concrete strategy do you all have? And I think that's probably the best and most effective way to increase outreach and accessibility when it comes to tech.
Yeah, I would certainly echo what Tara Lynn says as far as getting folks on board from the get-go. Originally I was hired in 2017 under a HRSA Innovation Grant to do telehealth and Project Echo assessments at the critical access hospitals. And at that point in time, it was very important to have administrative and provider champions that were really interested and engaged in this new technology implementation. However, when the pandemic hit, all those rules kind of went out the door, right? We had providers, healthcare facilities really just had to meet patients where they were at, and conveniently with regulation relaxations, that was a possibility. But champions from the provider and administrative standpoint are really monumental, and certainly facilitate new technology implementation whenever you're rolling things out under normal circumstances. With regard though specifically to rural communities and technology solutions or implementation, we're still having massive connectivity issues. I think when I reached out to rural health clinics to really get a firm understanding of what they were doing around telehealth, we talked a lot about the challenges from a cultural paradigm shift, whether within the community or with providers, just to get folks understanding the importance and application of technology, how to use the technology. With regard to your older patient population, there are some limitations around just the physical dexterity and actual ability to interact with the technology and how to use it. And so if folks were really saying things like applications that didn't require a download, but were really just a click and it all comes up, we're working well. EHRs with the integrated telehealth platform technology that's easy. I think, I sit on the Northwest Regional Telehealth Resource Center board, and there's a lot of feedback that we keep getting along the lines of, we need a really easy technology solution for patients and providers, because we've got clinics that are independent, we've got clinics that are part of system, and the resources that each have in order to get patients and providers up and going on these things are vastly different. And so a simple solution that's not really challenging is definitely key. And then keeping in mind that you have some communities that have broadband challenges. So technology that doesn't take a significant amount of broadband, or creative solutions like hotspots, parking lot hotspots, or just locations where folks can access devices and access broadband. And I think that until we solve the significant broadband challenge and equity issue across the state and really across the country, there will still need to be some of these creative solutions to address and implement technology.
Thanks for that. And, is there anything else you want to kind of highlight, Rose, about barriers that the rural community, other barriers that rural communities face when it comes to technology adoption in telehealth and other platforms?
Oh gosh, I mean, we could certainly talk a lot about challenges. I want to highlight first that there are a lot of innovative solutions to the challenges, as they touched on some of the creative solutions with broadband hotspots, and moving forward. Those are the types of things and kind of innovative thoughts around how to address some of these challenges that we'll need to continue to bring into the conversation. Technology lending, there are clinics that will lend out tablets to their patients or get them set up in the parking lot. Now we're starting to integrate back into more of the clinical setting. However, with sort of counties or populations where there's still a large amount of 65 plus who still have some reservations about integrating into the community, these sorts of tech solutions certainly need to remain in place. So one interesting piece that I did hear about was patient privacy. So when conducting visits, you're no longer behind closed doors. So patient privacy is something to take into consideration as, from, I guess, the administrative end as well as the provider end. But there's also a silver lining to that, as far as providers get to see into patients' homes and really get a more holistic understanding of the environment in which they operate in. Reimbursement, continues to be a large piece of the conversation. A lot of things kind of hinge on what Medicare decides to do around some of the relaxations, with FQHCs, RHCs remaining able to bill as that distance site provider, patients still being able to be seen in their homes. So those pieces are huge. We talked about the cultural shift as far as and challenges around most of the technology piece and connectivity. So I think I've kind of hit on a lot of the big buckets and challenges moving forward, and some of the potential solutions or short-term fixes to those. But a bigger part of the conversation as we move forward, and as we're all hearing, is broadband. So I think we'll have more to come on that. But I think the more there's a lot of grants and federal dollars out there as far as broadband, but the accessibility to that for some of our small, rural, independent facilities where you've got a provider who's also the administrator, and the time to actually pull together the data and all the information that goes into some of these broadband grants is substantial and really requires a contractor. So a lot of challenges, potential solutions. It will be interesting to see what happens in the next couple of years as far as broadband.
Thanks, Rose. And I'm glad that you changed it to innovative solutions. And I think I'd like to take that same tone and pose a similar question to Tara-Lynn and Eric. In your work, what are the innovative solutions that you've seen in regards to rural health, in regards to special communities, as was mentioned before, whether it be folks with or without visible or invisible disabilities, older populations or other populations that you serve? What are some of those innovative solutions that you've seen emerging with technology over the past year?
I'll start. Just again, from my perspective as at Multnomah County, I think a lot of the innovation I have seen has been at a more systems level, contracting with folks or with partners who we wouldn't typically contract with, partnering with community members to get resources out to specialized community. That's something that's unheard of from the county perspective. But so that has been awesome, and I think has also, in a sense, built a lot of trust in our community. So we were able to see a lot more of community needs because we were able to work, necessarily arm in arm with community partners who got resources out, and we were able to see firsthand and hear from community members firsthand about what they were going through, what they needed, what they need for the future. That we wouldn't have been able to reach before, just with our typical way of doing business. And so that has been really amazing, especially because we really focused on culturally specific partners. So yeah, that's one really big innovative way or strategy that we've been using for the last year.
So maybe I'll talk about two items. I think the first is similar to the first thing that we touched upon, which is the acceleration of some technologies that have been out there, but that COVID has really forced us to accelerate, and I think for the better. So, when we talk about, for example, in the context of clinical studies and reaching out to the rural communities, we have a different model from what we had before. That requires a whole, HIPAA and other privacy infrastructure. And so what we've seen is the emphasis on the development of software that is HIPAA compliant, the CFR 21 compliant, that really gives us a confidence that we can have these physician-patient interactions remotely, which is kind of a mainstay and a critical requirement as we think about this outreach. On a more sort of, we'll call it personal grail level, we obviously are working on a novel technology that will allow us to screen for, many types of cancers. We can detect 50 types of cancers using a blood test, and really simplifying that process and looking for cancers that people are at risk for that we haven't been looking for. Is a novel technology, and that given that it is a simple blood test, really will help us hopefully increase access to this kind of novel technology. And we talked a little bit earlier about the presence of PCPs in the community. and how that is even siloed. And if you think about the next level of specialists, that is even one step removed. And I think that in rural communities, both the presence and distribution of specialists is, much less than, of course, in sort of urban areas, and that's where I think that tests like blood-based multi-cancer early detection tests can be very helpful.
Thanks. And I want to kind of go back to something that was said earlier, and then I'm going to kind of switch gears a little bit with our questions. But earlier when we were talking about innovative solutions and the different special communities that everyone serves in their work, I think there's, this conversation is about resilience, and it's also about equity. And, specifically, we do have, a big disparity in the way that technology is built, the way that it is marketed, and then eventually the way that it's adopted. And a lot of that is also along racial lines and along language lines. And as mentioned by Rose earlier, also ability. Right. So when we think of technology that's built for English speakers, that is kind of marketed with, pictures of happy white families and kind of geared toward a specific type of family, a specific type of person, these type of this is not a exhibition of equity in tech. And so when it comes to more equitable structures in technology, what is some of the work that's happening in all three of your organizations that is more inclusive along language lines, along racial lines, and along the lines of other demographics and populations that you serve? Terilyn, do you possibly want to talk a little bit about what the county is doing?
Yeah, sure. I would say language is probably like the #1 accessibility approach that the county really puts a lot of time and effort into. Again, that same department, the health department, more specifically the public health communicable disease program and their facilities outreach and outbreaks team, they have a 2-prong approach to outreach to patients. And so what happens is they'll call a patient, and if the patient doesn't answer, they then receive a text. And then that text has a link, and that link goes to this information page. And they have, they are making efforts to make sure that those communications are in I shouldn't say every language, but as many languages as reported. And so, but again, it's just an effort, right? Because not everyone is using phones. And so we definitely have a ways to go, but the language accessibility piece is a huge one for the county currently. So when someone calls, reaches out to a patient or even a community member in this particular department, if that person who answers the phone is not English speaking, that county person can then grab an interpreter or figure out whatever the language is that is needed and get an interpreter to facilitate the conversation and share the information. And even our interpretation, our interpreters are, we partner with community-based organizations to bring in those interpreters. So it's definitely a collaborative effort.
Yeah, I will just add, you're absolutely right, Vanessa. The tech I think we've certainly seen a lot of the disparities with this rapid shift to everything being virtual. Simply the platforms that we regularly operate and communicate on, right? Just getting the fact of captioning or another language, that was definitely the first step in a lot of the education and outreach that our office engages in. But from the telehealth standpoint, we kind of work at a broader level with the national or NRTRC, the Northwest Regional Telehealth Resource Center, and as two sort of federally funded organizations that work in tandem to support the communities in which we serve. And there's been a lot of conversation around, making sure that we are more inclusive, being rural of our native populations and Latinx populations as far as representation on these boards. But it's been, and then, you know, kind of thinking about the strategies for outreach, education, and cultural language inclusivity with those outreach engagement efforts. It's been really refreshing to see on the federal level that some of the patient provider education materials are offered in various languages now. So, you know, sharing, disseminating that kind of information just to let our healthcare facilities and providers know that there are resources out there that exist in languages other than English. And it has been refreshing to see the health authority, you know, sort of change their approach to the whole pandemic communication to be more inclusive and be in different languages and stuff like that. So I think that there's certainly a more, you know, a longer way to go here, but it is nice to see that we're starting the conversation and, you know, kind of thinking more mindfully about how we deliver services and education using technology, how to use our partners and our resources that we have, whether it's within our system or, you know, partners externally, so that what we're delivering is as accessible as possible. But there's definitely, you know, room to go there as well.
From a clinical study perspective, it's critical to have obviously representation from a wide variety of demographics, and that is often dependent on having the appropriate translation. So, you know, we obviously, when we design a clinical study, we want to be inclusive and look at the different communities from which we can enroll. And then we have to make sure that we have study materials that are reflective of the demographics of those communities. So, you know, Rose and Terlyn both talked about language, and that's obviously a very, very prominent characteristic of what we need to do to ensure inclusion. I did want to just mention another concept, which is, of course, cultural differences, right? And so there are certain viewpoints that different you know, demographics have, and we have to be conscious of those, and we have to reach out to those different types of you know, cultural characteristics. And those cultural characteristics carry on to adoption of certain types of medical procedures, or fear of the medical system, fear of screening, attitudes towards screening. And so the language that we have to speak is not just the, you know, the English, Spanish, or what have you, but it's really also the cultural language. And those are the characteristics we need to be attuned to. And I think working with the PCPs and other physicians that directly interact with these communities and are part of the communities is going to be a critical part of our ability to be successful on this front.
Thank you so much for that. And before we kind of switch gears to Q&A, Eric, I'd like to kind of allow you to have the floor a little bit to talk a little bit more about what GRAIL does, and talk about the Gallery test, and talk about how COVID has impacted patient cancer treatment, and what promises your new technology may have to help not only the way things are now, but if we possibly have future disruptions in the care, such as during the biggest part of COVID, hopefully the biggest part of COVID. So if you'd like to just share a little bit about that, I'd appreciate it.
Thank you, Vanessa. So I mentioned at the beginning that, you know, COVID was really a great natural experiment, and what that natural experiment has shown us already is the pandemic decreased screening, cancer screening. And so, you know, that decrease in cancer screening, you know, was variable, you know, according to geography and access, but as great as 90% reduction in screening. What that will translate to is, of course, an increase in late-stage cancer diagnosis. And all of us know that late-stage cancer diagnosis means the poor survival. And so where cancer screening is really going to change, and we believe, and this is at the forefront of what GRAIL does, is that we want to change the language about cancer screening from one cancer at a time to how do we screen for multiple types of cancers. And so with a technology that's blood-based, we can think about access and availability out in the community, broad access. All you need to do is go to a blood draw station and get your blood drawn, and that gets shipped to the laboratory, and a result is returned. And the other element too is that we think about screening mostly around breast cancer, colorectal cancer, lung cancer, for very specific demographics. And so these are all one at a time. But any individual who goes into, for example, mammography for breast cancer screening is at increased aggregate risk for any other type of cancer. And so, when we shine the flashlight, so to speak, on just breast cancer, we're actually missing the larger piece of the puzzle. So the interaction between a blood-based multi-cancer early detection and current guideline recommended screening increases our opportunity to detect cancer earlier. And where that's important is, of course, that we obviously hope to improve overall survival from cancer as a public health problem. But I think the other element too is when we deploy it out into the community, we already know that rural communities have less access to cancer screening. And by having those conversations about multi-cancer early detection and its relationship with guideline recommended screening, I think that a benefit will be a holistic approach to screening, where a person can think about their overall risk and not think of it as an either or, but actually become conscious of their need to attend their guideline recommended screening, along with the opportunity to screen for cancers that have not been traditionally screened for. And therefore, in combination, really, as we roll it out to all the communities, improve the overall outcomes from cancer. And that's really the ultimate goal that we hope to achieve.
Thanks. And since this conversation is about equity as well, did you want to talk a little bit about Gallery and the health disparities testing?
Yeah, so Gallery is the name of our multi-cancer early detection test. And when we think about equity and inclusion, I think at the forefront is the idea of a blood test that can be widely deployed. And that's the first step. As I mentioned earlier, access is key to adoption of new technologies, and blood tests by definition is probably one of the most accessible technologies that are out there. That being said, that there's still a lot of work to do to make that access a reality, and that includes obviously working with regulators, with payers, because that, again, in the American healthcare system is often a roadblock in terms of adoption of new technologies, and so that is ongoing. There is legislation going through the Congress that is related to the opportunity to look at and think about how to do multi-cancer early detection and reimbursement for that. So that's obviously an important first step as we think about access across all of our different communities. And then the other thing I would mention is, and it's kind of reiterating what I said earlier, which is as we think about the different partnerships that we need to have partnerships that represent America and not just the major academic medical centers that sit in the big cities, right? And so we have to think about our partnerships with healthcare systems that represent the diverse swath of America that's often overlooked.
Thanks. And I apologize that I feel like I was reiterating. I didn't realize that Gallery was the name of the test. So now contextually, I was like, oh, I thought Grail was the name of the test. Now I know Grail is the name of the company, and Gallery is the name of the test. So I was like, oh, okay, now I get it. So I apologize for kind of asking the same question over. And I don't think I heard you say that was the name of this. So I apologize. Well, thank you all for kind of responding to our pre-drafted questions and getting this conversation started. And so now, for those of you who are on live with us here, please continue to put your questions in to either special events or to Skip as a Q&A so that we can respond to them in our last few minutes here. And so I'll start with one of the questions that came in. So this question is kind of discussing what we discussed earlier about new technologies and new programs, and making sure that these programs and new technologies are working and are being adopted by constituents. And the question is, how often should organizations or teams be reaching out to customers or those who are adopters of the technology? How often should organizations or teams be reaching out and gathering qualitative information to find out if folks are adopting these new technologies and how these new technologies are working. So essentially, share with us a bit about how in your work you gather feedback, two-way feedback about new technologies and new things that you launch to see if they're working, to see if they're adopting, and of course, how you respond to that information. Who would like to address that first?
I'm happy to jump in with that one because I often do a lot of qualitative information collection, and I think it's really, really helpful. And you walk a fine line between, reaching out too much and being obnoxious, and also reaching out to get constructive criticism and feedback. And I would just say, I think that it is really important to do that, but also to be aware of redundancy. Right. And so to understand who your partners are and how best to work with those partners so that you can really collect and maximize the outreaches and the engagement about what you have going on, and that you're really clear and mindful and take the time and initiative to create and maintain the relationships with various different partners throughout the state and community. So but yeah, I'm a big proponent of understanding how the technology is working or it isn't working. So there's so many different technology applications, and from the rural perspective, what works in one community clinic hospital may have challenges in another community clinic hospital patient population, depending on what the makeup is, Medicaid, Medicare, age, back to the whole cultural aspect of it. There's so many layers that feedback can be really helpful to make your product or resource better.
So in the context of what we've been doing with our multi-cancer early detection test, and one of the ways that we're collecting feedback is through patient-reported outcomes. And so there are validated tools around the ways that patients can react to various technologies, and they don't have to be new technologies, but obviously it was important for us to get that feedback. So we utilize these validated instruments that assess patient-reported outcomes, and we've actually asked these questions at various time points in individuals' journey through cancer screening. So we ask them before they even take the test, what do you think about screening? How does it fit into your world? And are you anxious? Are you worried? And what are your attitudes toward guideline recommended screening? Then after they get the result of the Gallery test, we actually ask the exact same set of questions. And we want to see what is the impact of receiving a blood test result on their perception of screening. And then we actually ask them a year later. And again, this is all doable in the context of a study, right? It's not as practical out in the real world, but it's actually valuable information for us as we assess, most importantly, what is the messaging that patients perceive, because the perception is their reality, and we can adjust that messaging based on our analysis of these patient-reported outcomes. And I think that that's going to be a critical element of our ability to gain that continuous feedback. And as we transition into Gallery being out in the public domain, we're going to transition to a state where we rely more on real-world evidence and real-world data. And we can take that data that we receive and really slice it up in many different ways. We can slice it up according to ethnicity. We can slice it up according to geography. We can slice it up according to age, gender, any other characteristic. And as we accumulate that data, we'll be able to iterate on the kind of messaging that we believe will resonate most. Again, going back to that concept of cultural approaches to cancer screening.
That was great. I have one question that kind of came up in chat a little bit. So for Terralyn in particular, with your role originally with the county with Sun Schools and working with kids, you then ended up taking on this project for a program that was more about connecting with a variety of different communities that maybe historically have not necessarily had the best access to public health services locally, and worked in a very cross-functional way. And there was a conversation I was in yesterday just with the city of Portland about some technology policy development in how to essentially reach people where they are effectively, and also be mindful of the fact that people often distrust government because they can't figure it out. It's like, you know, how to navigate local government is not an easy thing locally. There's lots of silos and departments and everything else. And so one like challenge in, you know, making sure there's effective engagement is helping people to, you know, essentially navigate local government. I'm wondering how much in your experience with the outreach work that you did was really effectively helping people understand and interact with local government to get their voices heard and the services that they needed met.
Yeah, no, thanks, Skip. I would say, I mean, even it makes me think about the last question that Vanessa just asked about, you know, like how often should we be, you know, getting feedback or getting data? And it really, for me, it goes back to like meeting people where they're at. So in terms of like serving folks and getting them the information they need, having their input on our strategies is 100%, like that's key. So when what we heard last year was, hey, we did like an interdepartmental ask of like, hey, the pandemic's happening. What are you hearing from your partners? What do folks need? And we kept hearing the same thing over and over. People need food, people need assistance for utilities, such as like, you know, bills and things like that. People need diapers, people need cleaning products. So just all of these different needs we were just hearing an echo of them. But what I heard was we need access to these things. So it's not just the actual thing, it's we need access to them. And so the way my approach was, okay, well, what we typically do is just give partners money and say, hey, y'all know how to work with your communities, get it out. But I was just like, well, let's change the narrative and say, hey, we know you all are working with these communities. Can we like arm in arm with you and go out with you and get these resources to folks? Like, how can we make these resources more accessible? And so I would actually like go out into the community with, whether it was like cash cards or food boxes, I would actually go out into the community and have, you know, folks meet me at places and give them things. And I think them having direct access to a local government representative who is actually very invested in hearing what they had to say, very, you know, just compassionate, I think opened a door. And so again, I bring that back to say when we were talking about how often you should be getting information, I really think that we have to be careful, because I think data in itself is or tech can be very transactional. And again, because it's created and most accessible to, you know, dominant culture. And so I think we have to change the way that we engage product, how we create things. And we do that by bringing those folks to the table. So I would say just being with community, getting their input and saying like, hey, this is what we're thinking. Is this what you need? What do you need? Help us create what it is. And to let's create a goal that we all have and then move forward. And then that way I feel like people just have more investment and trust is built, and you just see a lot more effective success or effective outcomes. And yeah, I hope that answered your question.
Oh, it definitely did. Sorry, I was on mute. And I think we've got another one that was just submitted, Vanessa. So take it away.
Great, thanks, Skip. Thanks, Carolyn. So we have a question from Anne, and the question is, if our panelists can share a little bit about how in your work you're able to make technology accessible or more accessible for older adults when it comes to making things easier or a little bit more simple to understand tech features in the work that you do.
I mean, I can start just because I typically work with like youth and families, but something I experienced last year and immediately responding to the needs of our communities. And some of our communities, it was very much just older adults who were needing resources. And while there are different communities that maybe felt comfortable with myself showing up to their homes to deliver something, some of these older communities did not feel comfortable with an unknown person showing up. And so what I did was worked with an organization that already had relationships with those communities and, gave them the resources. And I guess the question then is like, well, how did tech inform that? But tech informed that via survey, via signups. Like tech is such a big part of everything we do. And so I think that tech really helped us with the efficiency, getting the right amount of resources to a sufficient amount of resources to meet the needs of all those who were in need.
I was going to say that's a great question on the tech side of things. There's something that came up yesterday, was just about like people assume, well, everyone has access to websites and how to navigate them, but the reality is a lot of people are using cell phones and texts, right, to get information. And how can we focus on that? It's really really interesting. Sorry, I just wanted to share that. And looks like Rose wanted to say something too, so I'll retreat to the background again here.
No, that was a perfect a tangent to what I was going to say, and to touch on a piece that Carolyn mentioned is that technology is massive, right? And we all serve and partner with so many different organizations, and the Office of Rural Health being a larger sort of state organization that serves clinics, hospitals, as well as bringing together payers and health systems. And so another arm of work that I do is not technology related, but is really a part of the conversation, is our annual Forum on Aging in Rural Oregon. And so that is an event that brings together all of these different organizations to hear about challenges, but also to bring about innovative solutions to these challenges. Because like Carolyn mentioned, it is really the communities, the clinics, the folks that see and touch patients and community members every single day that actually know what the challenges are and have created potential solutions to them. So as a larger organization, it's really our job to reach out, engage, understand what the challenges are, and then bring that back in either an education, information dissemination route to model these innovative approaches, or to take it back to larger partners, national, regional, to say, listen, we've got some issues with the older adult population who are having real challenges with technology and the way that it's created, or the way that the virtual platforms are. And that information is heard at larger federal levels and does impact policy changes and things like that. And so just to think about, like, again, the big scope of technology and how it trickles down to the individual level, but also, is so important to be able to articulate that at a larger level to policymakers.
So if there are not any additional questions, I know we're in our last 5 minutes. Skip, did you want to do some wrap up? First, I want to say thank you before you say thank you. I want to say thank you to everyone who attended, who engaged, and to our wonderful panelists. And of course, to Skip for inviting me to moderate. This was a fantastic opportunity. And Skip, I'll allow you to wrap up our session for today.
Great. Thanks, Vanessa. And a big thank you to you for taking time out of your busy schedule to work with all of us and the panelists to put together a really great session. Really appreciate your time. And also, Rose, Eric, and Carolyn, it's been really interesting just to hear all of your various perspectives on this very important issue. And it won't be the last that we try and tackle the various parts of this topic this year. But we're really pleased with how the session went this morning, and look forward to sharing it out broadly with our network going forward. And thank you to our panelists for investing so much time with us as well. And also to all of you who joined us today live, and to all of you who will be watching this asynchronously on your spare time. Also wanted to just do one more quick sort of shout out, if you will, for some of the supporters of the Techlandia Summit, which include Comcast Business, Fortinet, Grail, and SAP. So thank you again for helping us to make this programming possible. And we look forward to seeing many of you over the next couple of days as well for some more programming. hope you all have a great rest of your day. And thanks again for joining us.